Hans Eysenk's provocative 1952 claim that psychotherapy was no more effective than spontaneous remission triggered 50 years of therapy research. The verdict: Eysenck was wrong about therapy's effectiveness, but the methodology he demanded, the randomized controlled trial, became the gold standard. Today we know therapy works. We know which therapies work best for which conditions. And we know that most therapists significantly underestimate how much their unsupported intuitions differ from evidence-based practice. The randomized controlled trial is the gold standard for establishing whether a psychotherapy works, its efficacy. Patients are randomly assigned to receive the treatment under investigation or a control condition, a wait list, treatment as usual, or an active comparison treatment. Random assignment controls for the possibility that treatment seekers differ systematically from non-seekers. Manuals standardize the treatment being delivered. Outcome measures assess symptoms before and after treatment. The internal validity of RCTs is high, but generalizability to real-world practice is sometimes limited by the stringent inclusion criteria, highly controlled conditions, and specialized therapists. Effectiveness research examines how therapies perform in real-world clinical settings, community mental health centers, primary care practices, and private practices, with typical clinicians treating typical patients under typical conditions. These studies sacrifice the internal validity of RCTs but gain ecological validity and generalizability. The gap between efficacy, what works in RCTs, and effectiveness, what works in practice, is an active research and policy concern. Consumer Reports magazine's 1995 survey finding that respondents reported therapy as highly effective and that longer therapy was better was an influential early effectiveness study using a very different methodology. Meta-analysis is a statistical technique that combines the results of many individual studies to estimate the overall effect of a treatment and to explore factors that moderate its effectiveness. Mary Lee Smith and Jean Glass's 1977 meta-analysis of 475 psychotherapy studies found an average effect size of 0.85, meaning the average treated client was better off than 80% of untreated controls. This was a landmark finding that established psychotherapy's effectiveness quantitatively. Subsequent meta-analyses have generally replicated this finding, with average effect sizes in the range of 0.7 to 1.0. The empirically supported treatments movement, formalized in the 1990s by APA Division 12, systematically cataloged specific therapeutic interventions with demonstrated efficacy based on rigorous research criteria. A treatment qualifies as well-established if it has been shown superior to control conditions or equivalent to another established treatment in at least 2 rigorous RCTs conducted by independent research groups, with a treatment manual and specified patient population. Probably efficacious treatments have only one good RCT or conflicting results. This system guides clinical training, insurance coverage, and practice guidelines. The empirically supported treatment movement has generated significant controversy. Critics argue that RCT conditions, highly selected patients, manuals that constrain therapist flexibility, short treatment durations, and specialized research therapists systematically underestimate the complexity of real-world practice. The movement's focus on specific techniques underemphasizes common factors like the therapeutic alliance, which predict outcome across therapies. Some argue that the EST framework disproportionately rewards CBT, which is easier to manualize and test in short-term RCTs, over therapies that work through relationship processes that unfold over longer periods. The scientist-practitioner model holds that clinical psychologists should function as both consumers and producers of scientific research, basing clinical decisions on the best available evidence, while also contributing to the evidence base through systematic observation, case documentation, and research participation. In practice, this means staying current with the treatment literature, using validated assessment tools, monitoring client progress with standardized measures, and questioning clinical intuitions that lack empirical support. The model is aspirational. Most practicing clinicians are much closer to the practitioner than the scientist end of the continuum. A consistent finding in psychotherapy research is that therapist differences account for more of the variance in outcomes than treatment type differences. Roughly 8 to 9% of outcome variance is attributable to the specific therapist, while treatment type accounts for only about 1%. This means that the most important choice in treatment is not which theoretical orientation to use, but which therapist. The characteristics of highly effective therapists include strong alliance-building skills, empathic attunement, flexibility, and continuous monitoring and adjustment of their approach based on client feedback. Scott Miller and colleagues have shown that systematically monitoring client progress using brief, standardized measures administered before each session significantly improves outcomes, particularly for clients who are not improving or who are deteriorating. Without monitoring, clinicians fail to detect deterioration in roughly 70% of cases, continuing ineffective treatment without awareness. When monitoring data signals that treatment is not working, therapists can adjust their approach, discuss the alliance, or make a referral. Routine outcome monitoring has been called the most important clinical innovation in psychotherapy in decades. Psychotherapy works. This is one of the most replicated findings in clinical science. The challenge is identifying for whom, using which approach, delivered by which therapist, for how long. The scientist-practitioner model, empirically supported treatments, and progress monitoring together provide a framework for ensuring that the average patient receives the average benefit that research demonstrates, rather than the highly variable outcomes that unsupervised clinical intuition produces.